Good morning, you guys. I'm all alone on my Q&A today. I'm super disappointed. But I wanted to run over just a couple of things for you guys and be able to post it. I know that it's hard to be online and not have access to us just right in our offices to ask questions. So we'll just go over a couple of objectives here, and hopefully that'll help you out. First of all, I just wanted to let you know, it was brought to my attention yesterday that on your calendar, there was a burn guest speaker for October 6th, and I have no idea where that's coming from. I looked all through everything that I entered and all through everything that has been put on there, and from the instructor perspective, we can't see it. So I went into yours and into the student view and deleted it from the calendar. That burn guest speaker was the one that came back on September 21st and talked to you guys from the burn unit at the U. Then from now on, we're going to start being in class on Monday. And so our Tuesday quizzes will be in class. They will be at 8 a.m. When we hand them out, we'll shut the doors. And if you're late, then you'll have to just wait outside until the quiz is over. And then you can come back in when we do the answers so that you've got that little bit of a review. So that will start this week on Tuesday. I know that you guys were planning the 2 to 10, take it online, and we just need to kind of bring that back in the classroom now that we're going to be there. So plan on that. I will post Monday and Tuesday's lectures by this afternoon, and that's when we will start the cardiac unit. It's a really big unit, and it has 4 or 5 PowerPoints. So I will place them under the title cardiac PowerPoints, and you will see that it starts at the beginning with the first one, which is the assessment and anatomy and physiology, and then it goes to ECGs, then it goes to pacemakers, then peds cardiac, and then Vicky. That's all my material. So I apologize. You'll have to see me and hear me for Monday and Tuesday for 2 weeks. And then Vicky will follow up with her adult disorders. So that's kind of how cardiac will proceed. The pediatric respiratory learning activity, you probably saw it pop up on your screen. I had not published it because I wasn't sure if we would have time for Daylin's activity. So during her activity, I just scrolled through the roll and took pictures so that I could see who was on there. And I will get in this weekend and give you credit for being there for that learning activity and being there for class. I think that's it. So let me just pull up my PowerPoint here, see if I can share my screen. All right, hopefully you are seeing what I'm seeing with the peds respiratory disorders. The second slide here talks about objectives. Number 2, identify the clinical manifestations and medical or surgical management of patients with tonsillitis. So when you're looking at your clinical manifestations, think about what this patient looks like. They walk into your office, and what picture would you build in your mind of them having a fever, having a red sore throat, having the white pustules or white streaks on the back of their tonsils? They build that picture in your mind with your clinical manifestations of what they look like. And then look at your medical and surgical management. So when they have their tonsils out, think about that post-surgical bleeding, the chance of hemorrhage, those first few days, first day 1, and a little bit day 2, but mostly day 1 is at risk for hemorrhaging. And then again at day 7. And if you remember, that's when the scabs fall off, is about day 6 or 7. And so they are at risk for having a lot of bleeding then too. So make sure you understand how to treat them and what to recognize. If you have a patient who's swallowing a lot, if you have a patient who might be drooling, who can't manage their secretions or seem like they have too much fluid in the back of their throat. So if you know, like when you have gum, your throat is a lot more moist, you'll swallow a lot more than you will if you have a really dry mouth. Number 3, compare the clinical manifestations and medical management of patients with various types of croup syndromes. So croup encompasses several different pieces to those syndromes. But what I want you to remember is that's airway inflammation, particularly upper airway inflammation. So part of your clinical manifestations are going to be upper airway sounds like stridor. They're going to have that croup cough. And if you don't remember what it sounds like, under the respiratory module, there are a couple of respiratory videos. And one of them is that little child that has the croup cough. Cold, cold, cold. If you remember that with croup, they both start with C. You want it to be cold to help decrease that airway inflammation. In your book, it has that little good news box that says that warm mist in the bathroom will be helpful. That's only if there's congestion. So if they happen to have a junky cough that has a lot of mucus production, then that kind of environment will help break up the mucus. But with your standard croup syndrome, it's just airway inflammation. Number 4, prioritize the nursing interventions for the child with ineffective airway clearance related to inflammation or obstruction in the upper airway. So think about your interventions. So your clinical manifestations, I guess, are number 3. And the medical management kind of goes along with your nursing interventions for number 4. But you want to think about what you're doing for inflammation or obstruction in the upper airway. So obstruction is going to be more of your mucus production and your cough, if they have a lot of sputum, if they need to be suctioned. Number 5 kind of feeds into that too. Identify the clinical manifestations and medical management of the child experiencing respiratory syncytial virus. So, or RSV. The clinical manifestations, think about these guys that they're just little snot factories. They're blowing booger bubbles, they're coughing, and they have a lot of sputum. Suctioning is part of your medical management that goes along with that. Also, because it's a virus, we don't give them any antibiotics. We treat them symptomatically. Humidified oxygen, fluids. Remember, if your child is breathing really fast, usually 60 is kind of the NPO spot. Absolutely nothing by mouth if they are breathing 60 times a minute. Use very close observation and good nursing judgment if they're in the 50s, because they're getting close to that. If they're breathing that fast and you need fluids, then you need to get an IV in them. Number 6, identify nursing care measures for a child experiencing respiratory syncytial virus. So I guess this kind of goes along with the medical management in number 5. But the nursing care measures are your suction, your humidified oxygen, your fluids, trying to make sure that they've got some way to get their nose cleared out and their airway suctioned. They will eat better, they'll sleep better, they'll drink better. They'll breathe better. They just do better if you get them suctioned, and they will require less oxygen. Let's see here. I don't know why it's not going to my next slide. There we go. Number 7, explain important teaching measures for patients and their families or support system regarding the spread of respiratory infections. That is hand washing, that's PPE, that's helping them not be, to kind of rein in that contagious illness and not pass it on. Make sure you're doing good teaching. The Batman cough, making sure that they are not reusing Kleenexes and that they're especially washing their hands. Number 8, identify the clinical manifestations and medical management of children experiencing cystic fibrosis. So what does that, what does that look like? Your clinical manifestations of cystic fibrosis. Well, this child is going to have, often have a cough. It's a chronic cough, and it can be a little bit junky, but it also can be dry. Just know that they have a chronic cough. Also, under your clinical manifestations, they won't be running a fever. This is a chronic illness. It isn't something that's acute. If they were to have an acute exacerbation with pneumonia or something like that, then yes, they would have a fever. But for just your standard cystic fibrosis, they won't. Remember that they'll have salty skin, that they will be kind of skinny, kind of a failure to thrive look to them. Those will be, looking at your clinical manifestations, will also be a meconium ileus for a newborn. Now, the steatorrhea is the fatty stools. Are you going to have fatty stools in a newborn? Nope, because they haven't had enough time to have food that's going to be an issue. So the meconium that's very sticky already is going to be kind of gummed up in their GI tract, and they'll end up with an ileus often. Not every time, but often. And that kind of cues them into the fact that there might be a problem, and they can run that test do the sweat chloride test for cystic fibrosis. The medical management is going to be their inhalers. Remember how the little boys that were in the video said they had albuterol, and they had hypertonic saline, and they had the pulmozyme, which is a mucolytic, and so it breaks up the mucus. Hypertonic saline, if you can think about that, it's got a lot of solute in it, and it's going to draw water into that mucus, into that airway where it's going to thin up, and they're going to cough a lot. And that little boy said that he coughed and coughed and coughed, and sometimes he threw up, and that was his least favorite one, doing all of the medicines that they have to do. Number 9, identify nursing measures for the child with cystic fibrosis who has an increased risk for respiratory infection, difficulty breathing, and compromised nutrition. So you want to look at the things that we do to help them not be at risk for more respiratory infections. That's going to be some of the like germs, helping them stay away from other cystic fibrosis patients that are colonized with different bugs. Difficulty breathing. Now, these guys, when they put on that vest treatment, they need to really be doing it morning and night at home, and it can take close to a half an hour. And then they come into the hospital for cleanouts. They come in sometimes quarterly, sometimes once a year, sometimes not till it's been 2 years. Sometimes it's every other month. It just kind of depends on how they're doing. But they come in and they ramp up their vest treatments to 3 and 4 times a day. They give them more antibiotics and a PICC line, and they give them more breathing treatments to hopefully kind of give them a jump ahead. With the difficulty breathing, once they have done those vest treatments, it makes them cough quite a bit. And so then they can bring up that mucus, and you just give them the handheld yonker suction, and they usually can suction their own mouth after they cough. The last part of that is compromised nutrition. Need to absolutely positively make sure they are taking their enzymes. Sometimes it's 3 or 4 or 5 or 6 usually it's like 5 or 6 or so with a meal, and 3 or 4 with a snack. As they grow, those enzymes can become more the bigger that they get. With that compromised nutrition, make sure that you look for things that are showing that they're getting the nutrition that they need. And that's in their stool with the floaters and sinkers. That's in gaining weight, looking less wasted or like they've got failure to thrive. And the things that we need to be doing for their nutrition as far as having vitamins that have, usually they're prescription vitamins because they have very high doses of fat-soluble vitamins in them. And most of us cannot take that kind of vitamin. They need to have a lot of salt, a lot of water. I had one patient one time that said, I can salt my potato chips if I want. And so just make sure that they've got all the nutrition that they need there, but especially their enzymes. Number 10, identify the clinical manifestations and medical management of patients experiencing various types of asthma. Okay, so with asthma, that is lower in their airways. So even though they have smooth muscle constriction, They have the airway edema, so the mucous membranes are kind of swollen. The airway is kind of swollen. They also have a slight increase in mucus production. Now, this mucus with asthma isn't thick, sticky, copious secretions like with cystic fibrosis or like with bronchiolitis. There isn't something that makes that very, very difficult to get up and a need for suction. Number one, it's too low in the airways to be able to suction. And number two, it's just a little bit thin and watery and slightly more than what they already have in their airway. So when you say hypersecretion, it just means more. It doesn't mean copious amounts. With medical management, those are your beta adrenergic agonists. Number one rescue medication is albuterol for that beta 2 agonist. You want to make sure that you remember that. Now, they will also give, just with or shortly after, a systemic corticosteroid, usually methylprednisolone or dexamethasone. And they will usually give it to them IM. They've got a little bit more even absorption with that, and it's systemic. So as the albuterol starts to wear off, then they will have coverage as far as making that last a little bit longer because the steroid has a longer half-life, sometimes 36 to 48 hours, depending on the steroid and the dose. And then remember what the difference is in, like, the red was the critical management, the yellow or orange kind of was more you're kind of approaching to where you might be in trouble, so we need to get this fixed. And green is your basic everyday management if you need to take an everyday inhaler. Like sometimes people take Atrovent, sometimes people take an Advair disc, sometimes people just take Singulair for allergies. So it just kind of depends on what they take for their triggers. Number 11, explain important teaching measures for patients and their family or support system regarding education guidelines for the management of asthma. So what are you going to teach them about it? Well, you're going to teach them about triggers. All of those triggers. If it's a poor air quality day, they should be inside. If they got worse when they have a new pet, the pet probably has to go. Don't smoke around the child. When they have an upper respiratory infection like a cold, then having a cool mist humidifier or having things like that help keep them being able to, like, keep the airway inflammation down and being able to manage that hypersecretion of the mucus. So most of the time they will have rescue inhalers for their albuterol, but they'll also have their daily medications, and all of those will go up. They'll increase in frequency if they're having a lot of triggers that are really kind of pushing them over the edge. And then when Daylin was talking to you, she told you about some newer technology about how they can manage, how they can record how much the child is using their albuterol, like at school or something, with the little meter that goes on their inhaler, on their metered dose inhaler. And they'll be able to see, and parents can upload it to an app, be able to see how much they're using their inhaler. And they can carry their inhaler to school now. About 18 years ago, they couldn't. They could have it in the office and they could have it at home, but that was it. And so, and you had to have a doctor's order, and it was really kind of crazy. Well, I had a son who had asthma, really struggled with it until we kind of got his allergies under control, and he had a 45-minute bus ride. So I had taken care of a patient that had an anoxic brain injury on a bus while she was on a field trip, and she had an asthma attack and they couldn't get her help fast enough. So I was not going to set him up for that. And so I put one in his backpack. But at the time, they said if you're caught with it, that it would be like having drugs and you would be suspended from school. So he was always really nervous. Then the American Lung Association put out a bunch of flyers for parents of children that have asthma or that have asthma themselves, but mostly they wanted children in the study to be able to do some focus groups and see if they could pass some legislature on carrying their inhalers. So my son and I worked with this group, and we were able to go up to Capitol Hill and be able to work with them so that the kids could carry their inhalers. And the bill passed, which is pretty amazing when you think about it, because these kids were being afraid to carry their own rescue medication. It would be like being afraid to carry an EpiPen because it could save your life. And so if you think about that story and you think about albuterol, that's the rescue med that's going to save their life. All right, let's see here. Okay, that's it for our objectives. I'm just going to see here. I'm going to stop sharing my screen. And I still am the only one in this conference. I'm so bummed. But that's okay. Hopefully that helps you kind of just reiterate a few little important points. But make sure that you're remembering your ABCs and how to monitor their airway. Keep those upper airways suctioned, lower airways having the albuterol. Upper airways are the croup syndromes, and so having a lot of stridor and using cold therapy. And one of the croup syndromes is epiglottitis that we talked about too. And epiglottitis, remember the hallmark symptom of that is drooling. So if they have stridor and they're having upper airway constriction and edema and they have croup-like symptoms, but they are drooling and they can't manage their secretions, that is a life-threatening situation, and that is epiglottitis. You probably won't see it. In 20 years, I've seen 2 cases. And one was not directly my patient. I was the charge nurse. But the other one I took care of, and boy, it was pretty quick that we got in there and got them intubated to be able to manage that airway. So just know that they can lose their airway pretty quickly. Anyway, I hope you guys have a great day, and I hope you have a great weekend. And I am really looking forward to seeing half of your cute faces that are unmasked in class on Monday. So peace out until then.